So we'll be looking at the current treatment paradigms, the newer decision paths, algorithms, and the expert opinions throughout the session. So just to keep it short and give maximum time to the discussion, I would like to hand over the session to Dr. Paras Mehta as she will be moderating the session now. Dr. Mehta, over to you.
Yeah, good afternoon, everyone. In the interest of the time, I would not take much time to introduce the subject, but I would just request the first speaker, Dr. Sayan Basu, who is a clinical scientist from LV Prasad Eye Institute, doesn't need any introduction. He would be talking to us on overview of dry eye.
All right.
Over to you, Dr. Sayan.
Thank you so much, Horace. Uh, Good afternoon, everyone. So, I'm already a little bit delayed, so I'll be brief, crisp, and hopefully we can have a little bit of interaction during the session, a little bit of Q&A. Okay. So, I'll present very quickly on what I think about dry eyes and how I think that we can approach it in a way that we can give the best outcomes to our patients. All right. So a lot of the work that we're presenting is not just my own work. We have a very large team that works together dealing with these very difficult patients. Most of them have chronic illness and they've been suffering for a long time and they have other complex issues. So it's not possible to present this without acknowledging their support. We are also very fortunate that we have a very successful and productive collaboration with the Narayan Netralaya group in our dry eye efforts, and we try to work together. One of the examples of this collaboration was the dry eye special issue which came out in the Indian Journal of Ophthalmology last year in April. For those of you who haven't had the chance to look at this, please take a look at this wonderful collection of over 60 articles which really addresses dry eye disease from A to Z, and you will find that you'll find those articles very helpful, particularly the review articles and the consensus papers. So I'll just highlight a few of them. The first one is on aqueous deficient dry eye disease. These are preferred practice pattern guidelines on clinical approach, diagnosis and management. Again, all of these IGO articles, as you know, are free to download. They are open access. You can also scan the QR code on the screen and get to the article directly. There's also another one on evaporative dry eye disease. This is particularly very useful because it gives a very, very lucid and practical approach to managing evaporative dry eye, which is the most common form of dry eye that we see in the clinic, and often is very challenging because we are not able to make sense of what to do. But you'll find there's a section in this article also on patient counseling, which you'll find very useful. And then this paper on topical and systemic immunosuppression in aqueous deficient dry eye disease. I think we'll talk about this during this session as well, where you will realize how how to basically optimize immunosuppression therapy and not to use it as blanket therapy everywhere, and how that can give you good outcomes. But this gives you a very good overview. So please take a look at these articles as well. I'll start with a few clinical cases. The first one, this patient is a 35-year-old teacher who complains of foreign body sensation, grittiness, dry eye symptoms, has about 6 to 8 hours of screen time, complains of burning sensation in both eyes. Patient is male, good vision, there's just a tiny bit of corneal staining, a few spots, normal TM meniscus height, normal Schirmer's, and a little bit of a less nid bud. So this is the meibography image. You can see the meibomian glands are a little bit distorted over here, curled, and you can look at the morphology and see that this is not normal. And there are some areas of dropout as well. You can see that in parts of the eyelids, the glands are shortened. So this is a very easy diagnosis. What is this a case of? This is a case of evaporative dry eye meibomian gland dysfunction. So you will treat the patient along those lines, okay? But you can also have sometimes, and this is why I think meibography is useful, you don't necessarily need a high-end equipment, but if you have any infrared camera, you can image these glands. Sometimes you have cases with a more severe presentation. This is a 29-year-old female, exactly same symptoms and presentation in terms of the clinical signs, but you can see on meibography that the glands are completely atrophic. Now these are two ends of the spectrum of the disease, but it's important to recognize that meibomian gland dysfunction can also vary in terms of severity. Because in this patient, if there are no meibomian glands, then you cannot get them to function again by your targeted therapy at the meibomian gland. And there are very good ways of doing it, but it just won't work in these patients. So it's important to distinguish how you can personalize your treatment based on what severity and kind of pathology the patient has. Why do you think this patient has dropout? She's only 29 years old, very young female, healthy otherwise, but no meibomian glands. Any guesses? What kind of drug? So you're very close. This is basically because of the fact that the patient is on treatment for acne. So retinoids which are given for acne, you know how they work. They basically work by acting on the sebaceous glands and causing sebaceous gland atrophy, because acne basically is sebaceous gland hypertrophy. And the meibomian glands are nothing but modified sebaceous glands. So patients who are being treated for acne, patients who are being treated for PCOD, who are on hormone replacement therapy, can develop meibomian gland atrophy. So it's important to recognize. So if you see a female patient, young or middle-aged, who has severe meibomian gland dysfunction, evaporative dry eye, don't forget to do a meibography and look for atrophy of meibomian glands. So otherwise, the treatment is very straightforward. You give lubrication for symptomatic relief. Blinking is very important in addition to warm compresses. LipiFlow, IPL, Thermoflow, all of these things work, but it's important to understand, and we highlighted this in the review article as well, that many of these treatments need to be repeated. So you have to understand that it's not like cross-linking or not like LASIK. This is how sometimes it is marketed as. It's a one-time treatment. It's not. You can do it, it will benefit, but for a short period of time you will have to repeat it. And please, in these patients who have severe disease, keep it in your mind that this could be a reaction to hormone replacement therapy or to PCOD or acne treatment, and take that history. The other gland that we often don't talk about in dry eye disease is the lacrimal gland. This is a very easy test that I would recommend that all of you learn and use in your clinic. We call this the direct assessment of tear function, or DATS. You just take a fluorescent strip, dry strip, just like you do a Seidel's test, and you touch the lacrimal gland with it. You can expose the palpebral lobe of the lacrimal gland by just pulling on the outer canthus and asking the patient to look down and out, and the palpebral lobe will prolapse just like you see in this photograph, and you usually see this nice lobulated structure. And when you touch the gland with the strip, you will see the aqueous drain out, the aqueous part of the tear film drain out of the glands. Remember, the only caveat here is don't use topical anesthesia. Don't use topical anesthesia in general while evaluating your dry eye patients, because there is a reduction in the reflex arc and the patients will show symptoms or signs of dry eye because of the anesthesia itself. So that is one important caveat. So this is a very easy test, just putting the strip on the lacrimal gland and looking for effusion of fluid. And if you see 3 to 5 spots through which fluid is briskly flowing out, it means that the patient does not have aqueous deficiency. And then you look at other causes. If you find that the number of openings are less, 1 or 2, and the fluid is not coming out immediately, that means that there could be aqueous deficiency. It's a much direct and better assessment of the lacrimal gland function than Schirmer's, which is a surrogate measure, because you're looking at how much fluid is there in the cul-de-sac, and that fluid may not necessarily be from the lacrimal gland. It could have been just drops that the patient has put before entering your clinic room, or it could just be the topical anesthesia that you're using. So in lacrimal gland dysfunction, the most common cause is Sjogren's syndrome, which is autoimmune. Therefore, you must, if you're managing these patients, collaborate with a rheumatologist, and anti-inflammatory therapy, both systemically and topically, is very important in the management of aqueous deficient dry eye. And consultation with the rheumatologist is important. Also, do keep in mind that patients who are on neurological medications, particularly antidepressants and sleeping pills, can also manifest this pseudo aqueous deficiency where the lacrimal gland is just slow to function. So do take a history if they're on those kind of neurological medications, and sometimes reducing the dose or stopping the medications themselves can relieve the patient of the symptoms. In general, we look at all of this. Typically in aqueous deficiency, you have this intrapalpebral SPKs or staining. Patients have history of, if they have history of dry mouth or joint pains, then it's probably Sjogren's. They can have a history of bone marrow transplantation or hematopoietic stem cell transplantation, where the cause is GVHD. and they can also have skin or mucous membrane involvement and conjunctival cicatrization. This is something that we often miss in patients with aqueous deficiency, and you should look for other signs of conjunctival damage in these patients. And typically they will have low Schirmer's, low DATs, and low TMH and Nidbud. So this is typically what a patient of Sjogren's looks like: interpapular staining, low Schirmer's, low DATs. And if you investigate, send the patient to a rheumatologist, investigate, then you will find that they are serologically positive for something. In this specific case, the patient who had rheumatoid arthritis, anti-CCP was positive, rheumatoid factor was elevated, ANA was positive, and the patient was put on systemic medication for the same. This also shows staining. This is also aqueous deficient dry eye, but this is not because of Sjogren's syndrome. You can see here the staining is very different. It's localized in the right eye to the nasal half, and in the left eye only towards the superior and inferior cornea. So it's very easy to, this is obviously aqueous deficiency, but it's easy to confuse this with Sjogren's syndrome, and you can start the patient on anti-inflammatory, etc. It will not get better because the pathology is somewhere else. So here the reason is lid margin keratinization because of Stevens-Johnson syndrome. So if you have a patient of aqueous deficiency, please look at the conjunctiva for signs of cicatrization, because then otherwise you might miss the cicatrizing causes, which are rare but more difficult to treat, like SJS in this case. And there are various causes of cicatrizing conjunctivitis, and you can go through this review article as well, and you can again scan the QR code if you want for download the article for free, where the very nice algorithmic approach is described. But in general, it's basically because of 4 diseases in our population. The most common is Stevens-Johnson syndrome. They have a history of a dermal disease where there's shedding of the skin, etc. It can also be because of mucous membrane pemphigoid, where you need to refer the patient to a cornea specialist and ocular surface specialist, where this requires very specialized therapy. Dr. Sangwan will talk about it. And it could also be drug induced. This is very common, and often we miss out on this. Again, another very nice review article on this topic. Most commonly due to topical anti-glaucoma medications, but it can also be because of systemic medications. Nowadays, the commonest form that we see is because of anti-diabetic medications like gliptins. So gliptins can cause a disease which is called gliptin-induced bullous pemphigoid, which causes conjunctival cicatrization and dry eye. So in these patients who you are suspecting with pemphigoid or cicatrizing conjunctivitis, please take a history of use of oral gliptins. Okay? So this is very common now with the use of preserved glaucoma medication and the very, very rampant use of gliptins for the management of diabetes. They're very good drugs. They don't cause hypoglycemia, but they cause ocular surface disease. Just last 30 seconds on the treatment. We know we have so many options, and I like to divide it kind of into these 2 groups of lubricants and anti-inflammatory therapy. In lubricants, you have these choices. On the anti-inflammatory side, you have the other choices. Remember to use topical steroids very sparingly, only when there is acute exacerbation of symptoms and flare-ups. And typically in aqueous deficiency, I will use a CMC 0.5% as my base drug. 2 reasons. One, frequent application, and therefore you have to understand that there is a financial element to this dimension to this equation, and CMC 0.5% is price regulated, so it's easy for patients to use this as a sustainable therapy. Topical cyclosporine is very, very important in the management of aqueous tear deficiency. It's very good now that we have so many alternatives, options in terms of topical cyclosporine. In evaporative, you would use one of the more viscous tear substitutes, and there the role of anti-inflammatory medication is not so much. This is what I will leave you with, the final algorithm. So consider dry eye disease in patients who complain of it, and confirm. You don't need too much fancy equipment to diagnose dry eye disease. You just need a fluorescent strip. So with the fluorescent strip, look at staining. If there's staining on the cornea, if the breakup time is low, then the patient has dry eye disease. So symptoms plus staining plus low breakup time is that. And then you can also use the Schirmer strip to do a direct assessment of tear function of lacrimal gland and differentiate whether the patient has meibomian gland dysfunction or lacrimal gland dysfunction. Then you categorize. I think it's very important to separate these 2, where the lacrimal gland is involved and where the meibomian gland is involved, and treat them as such. And in evaporative, you also need to, in some cases, I showed you meibomian gland dysfunction, but you can also have evaporative dry eye because of exposure. And so nocturnal lag of ophthalmos is something that you need to rule out in some of these patients. And then finally, in aqueous deficiency, like I said, differentiate Sjogren's from cicatrizing and treat based on the cause, and the other speakers will allude to this in the end. So in the end, dry eye disease is a huge spectrum, and you must narrow down the cause. Treat the cause first and then treat the symptoms. Right now, I think the mistake that most of us do is that we only give palliative or symptomatic treatment to dry eye disease. It's a little bit deeper than that. So it's important to make these distinctions and then treat the patient based on what they actually have or what is causing the dry eye. Thank you so much.
Thank you, Dr. Sayan, for simplifying that complex subject so well. And I would like to invite, before we go on for the questions, I think we'll finish up with the talks. Yeah, I would like to invite another luminary, Dr. Virendra Sangwan. He would be talking to us on role of immunosuppressives in dry eye.
Can we have the slides in front? All right, thank you very much. And Sayan has very nicely summarized the thinking. I'll just try to present an evidence and the thought process that dry eye eventually becomes a immune-mediated inflammation, and how do we treat that. So when we talk about the ocular surface, we should think about the three elements. These three elements are the preocular tear film and its component, surface epithelia, which means all the epithelial surface facing the environment, and ocular surface sensitivity. So you must think dry eye or the surface as a unit of these three components. The conjunctiva, which forms a smooth, flexible covering, it is essential for the integrity of the tear film and corneal transparency. So when you look at, and the immune system, the conjunctiva associated lymphoid tissue, they all play a very important role in maintaining the moistness. So the epithelia is needed to maintain the tear film. Tear film is needed to maintain the corneal epithelium. And these are the other way of thinking about the stable preocular tear film is compositional factors and the hydrodynamic factors. So not only look at these, assess these functions also when you are examining the patients with dry eye. So the stability of the ocular surface and tear film is very important to understand that there is an interdependence between the epithelia and the preocular tear film and the motor components, meaning the lid anatomical structures and the lid movement and tear drainage. In DUSE 2, we defined that the dry eye is essentially instability of the tear film and a potential damage to the ocular surface, and this results into hyperosmolarity and the inflammation. Once the inflammation sets in, then it leads to basically activation of the T cells, and those T cells are in the conjunctiva associated lymphoid tissue. What these cells do, the epithelial cells, which are the surface epithelium, they start secreting pro-inflammatory cytokines. They upregulate inflammatory genes, and then you see upregulation of all the inflammatory markers. There is a lymphocytic infiltration, including on the conjunctiva and the glands, and also there are hormonal derangements. If you have diseases like OCP, Stevens-Johnson, or GVHD, or Sjogren syndrome, that is not only dry eye. So that you must distinguish that those patients would need systemic treatment, and topical treatment alone is not sufficient. Similarly, like patients with severe VKC, these are the patients who are not just dry eye or allergy, they need much more stronger treatment, especially when you have presentations like this. They would cause stem cell damage, dryness, keratinization, and the surface toxicity contributing to leading to that surface disease. And these patients, I prefer to treatment, especially if you have moderate to severe disease, then treat them with systemic immunosuppressives. I'm not going to talk about the details of systemic immunosuppressive because we have published quite extensively on those topics. If there is a mild VKC, maybe yes, lubricant, mast cell stabilizer, and as and when needed, mild topical steroids may be okay. But moderate to severe, I would strongly recommend use systemic treatment. Sometimes you may be okay to use supratarsal steroid injections when there is a limited upper tarsal disease where you don't want to expose the patient to systemic treatment. And this also may work especially in the acute or relapse when it happens frequently. This is the role of topical cyclosporin in VKC, and VKC, this to me is only mild or maybe early moderate disease, but not in the severe diseases. Similarly, there is a good amount of evidence that I have been using cyclosporin 2% from very early on, 98, 99. We used to make ourselves. Now we have these preparations available. So again, back to the core mechanism of the dry eye. Remember that we said there is a pro-inflammatory cytokine and activation leading to the tear film stability. And one of the examples is, very typical example is Sjogren's syndrome, which is primarily a systemic disease but affects the glandular structures. And here both topical and systemic immunosuppressive will be required. Cyclosporin, especially when it is available in the formulations that nowadays what we have, helps to prevent the apoptosis of conjunctival epithelium. Remember we said there is a upregulation, so it down-regulates and protects the topical cyclosporin regulates the epithelial apoptosis, induces apoptosis of activated T cells, meaning the cells which are active on the surface, and they will be tackled by the cyclosporin. It also inactivates the T cells. It inhibits release of pro-inflammatory cytokines. So essentially, when you think of a patient who has, like Sayan was saying, that if you have a surface staining and patient needs topical steroids, think of adding topical cyclosporin. If patient have a systemic disease, alone these topical treatment will not be sufficient. And now you have the ophthalmic emulsion, which is good as it BD doses. So I won't go, this dry eye disease due to management plans are available, and I'm sure this will be repeated many, many times over. But the plan presented and that Sayan and Saran, which they have published recently in 2023 AIOC, I think is an excellent article, and all of you should read those. That will help you to develop your own algorithm and make your own plans. So in summary, all forms of dry eye eventually are immune mediated. That one thing you should remember with whatever the type of it is. So therefore topical or systemic immunosuppressives are necessary depending on there is a systemic involvement or not. And dry eye associated with systemic immune mediated diseases like OCP, Stevens-Johnson, Sjogren, VKC, GVSD, they cannot be treated only with topical. You need systemic treatment, and think about managing and where these immune mediated cells are coming on the ocular surface. Thank you very much.
Thank you, Dr.
Yes, sir.
Sangwan.
I don't. Yes, sir. It's available. I really don't have much experience, direct experience of using, so I'm not able to comment. But I don't know whether it is an immune modulator or not. Anyone of you have used Sayan, or any of you?
Actually, I have used at mine.
Your own eyes? Yeah. So do you feel?
For 3 months.
Did it help?
Little bit minimal. I don't know whether
Chalo, if maybe it is a belief, and if it's working, good.
scientific thing I'm saying.
Now, scientific, I'm not really aware. Sayan, do you have any specific?
Small thing that you need to be careful about with both chloroquine, and there's also retinoic acid which is in the market as a gel, is that they are phototoxic. Okay, so if you are otherwise healthy and you are using it, if you have an adequate tear film, then it doesn't cause too much of a problem. I don't know how much benefit it causes, but you should be careful that it can cause a lot of surface toxicity because it's photosensitive, particularly if you're using it during the daytime. And particularly retinoic acid, but chloroquine also causes it. So patients who already have ocular surface disease, and if you give them chloroquine or retinoic acid, they can get much worse. So I am not sure of how much benefit they cause in patients with inflammatory dry eye, but I am aware of the fact that they can definitely cause damage. So you have to be careful.
Photosensitivity, of course, we can discontinue at that time. Does it affect on the macula also?
No,
I
not
am
on the
not
macula, not macula, but surface epithelium. No, like there are many drugs now which are like people for glaucoma they use, but they do cause severe ocular surface problem. Yeah. So I need to leave, if with your permission. If there's any question for me, I can answer in next 1 minute, and rest I would like to leave because I have to have to catch a flight.
Okay.
How long we should continue cyclosporin? What are the criteria of omitting it?
See, the topical cyclosporin, if you want to use, you should at least try for 2 to 3 months. and that alone you should not start. I would start topical steroids, lubricant, and cyclosporine. And once you taper off and switch off the steroids, topical steroids, and then continue for 2 to 3 months. And if there is a patient feels that yes, there is a subjective benefit, and also the need for topical lubricants has gone down, I would continue at least for a year or more. Some of my patients are using for more than 5 years now. And then you only twice a day cyclosporin drops, nothing else. Antioxidants I don't use generally. I don't use any antioxidants, either drops or oral. I think the oxidants, as long as you are eating normal balanced diet, I don't think you need any extra. Unless you believe that is helping, it's your choice. I don't use. I use in pediatric age also. Minimum age, I've used as old as 6 year, 7 year old, but that is for mostly VKC, not for dry eye. Yeah, VKC I've used in the young kids less than 10 years old. So it's not like 2 or 3 years, I don't see that frequently, the VKC, but 5 year, 6 year old I use. And they like either use topical cyclosporin or tacrolimus, but I prefer in young kids tacrolimus at night once, and during the daytime use other medicines with minimal drops. And if you are using systemic, then I don't need to use anything topically, because it becomes very good compliance issue. I think rest of the question, please ask them and they will enlighten you. I'd like to take your permission. Thank you very much.
Thank you, Dr. Sangwan, for being here and being part of it. We can take some more questions later, and I would invite the third speaker, Dr. Bhaskar Srinivasan, who would be speaking to us on dry eye and systemic disease.
A very good afternoon. No financial disclosures. So basically, when you're looking at dry eye and systemic disease, you're probably looking at primary, secondary Sjogren's, SJS, OCP, GVHD. These are the common conditions that you'll be looking at. My talk would primarily focus on the primary and the secondary Sjogren's. So when you're looking at a patient with a collagen vascular disease or an autoimmune dry eye, you're looking at either dry eye, you're looking at scleritis, you're looking at necrotizing scleritis, sterile melts, and then when you have to do a cataract surgery, and then you need to know how to plan the surgery. So when you're looking at dry eye, you're looking at the aqueous tear deficient patients who generally tend to have a history of dry mouth or a history of small joint pains. They could be on other medications which could actually aggravate their dry eye. And once you have ruled out any other cause, then you would want to investigate them to find out whether they fall into the primary or the secondary Sjogren's thing. So sometimes it might be the ophthalmologist who would identify it and refer it to the rheumatologist, and sometimes it might be a known rheumat patient who the rheumatologist is referring across to you to take care as far as the dry eye part is concerned. How do we evaluate them? Obviously, you would be looking at a questionnaire. You could look at quantification of the tears with the Schirmer's, with the tear meniscus height, the lacrimal gland flow, which Sayan mentioned. Osmolarity is more of a research tool. You would look at the fluorescein grading or staining of the cornea and the ocular surface. You would look at the breakup patterns and the time of breakup, which would tell you what is the severity of the aqueous form. And for the meibomian gland, you would probably look at the meibography, and you would look at the lipid layer thickness, which would give you an idea, and the expression of the meibum, which will give you an idea about the extent of meibomian gland dysfunction. How do we manage them? Obviously, it's going to be a step ladder pattern, which is Dr. Sangwan already mentioned. Based on the severity, you would need to see which is more contributing more, whether it is the ATD which is more or it is the MGD which is more, and then base your treatment algorithm based on the DUCE2 or the TFOD classification. So if you're looking at an ATD component of dry eye or Sjogren's, why are you worried is because these eyes might have significant staining of the ocular surface, which could result in a breakdown of the ocular surface, resulting in infections or melts. And we want to intervene because we want to improve the symptoms, we want to improve their vision, and if we are planning an elective surgery, we want it to go uneventfully. If you're looking at how do you address them, obviously lubricants are our first medication. We would be looking at immunomodulators in the form of cyclosporin. But in certain situations, for a short period of time, you might want to use topical steroids. Topical steroids are not to be used on a long-term basis. These are just for that acute exacerbations. But what is important, especially as far as Sjogren's syndrome is concerned, is to manage the disease with the help of a rheumatologist, and you would need to control the disease with systemic medications as such. So if the disease is not getting controlled with the topical drops, the immunomodulators, you need to use steroids more often, then you're looking at going to the next level of treatment where you would be looking at blocking the puncta, whether with plugs or with cautery. And how does this help? Is it basically stabilizes the surface by retaining whatever tears are there on the ocular surface, reduces the need for us to put the patient on regular bouts of topical steroids, and makes them less dependent on the lubricating drops. So let's go through certain cases. This was a patient with joint pains, with dry mouth, with dry eyes. She already had a LipiFlow done elsewhere with very minimal improvement in symptoms. Serologically, she was negative. So this is the eye and the findings. So very low Schirmer's, TMH is low. There's a diffuse staining on the ocular surface, not much of flow from the lacrimal gland. So already most of the treatment algorithm was already done. Lubricants was already on, cyclosporin was already on, LipiFlow was done. So then we had two things to look at. One, whether there's a systemic component to the disease, and second, what we can do to improve the aqueous phase as such. So when you look at the LipiFlow and the IDRA here, again, it does show a decrease in the lipid level, but not a very sick. So you still have ATD component which is more, but MGD component is also there. It's not that a pure ATD component is there. So this was diagnosed as a level 3 deuce, significant ATD with MGD. Blood tests were negative, but the rheumatological consult revealed it to be a sero negative RA, and this patient was then started on medications for her RA and also underwent tear conservation strategy in terms of a punctal cautery. And post-punctal cautery, there was a marked improvement in the ocular surface with the Schirmer's value improving, the TMH improving, the surface staining significantly reducing. Even in the investigative tools, you can actually see an improvement in the blink. You can see an improvement in even the lipid layer, because once your aqueous phase improves, the lipid layer also spreads a little bit better. So the value that you get in terms of the machine will look a lot better. So that was with the IDRA, and this is with the LipiView, where you're actually seeing the lipid layer of almost 100. So when you're looking at any of these equipments or machines, if you see a value which is too high, you can still have to sometimes take it with a pinch of salt, because if it's a diffuse staining surface, also the LLT might actually be high because it's not spreading across the surface. Similarly, just addressing the aqueous phase also might actually improve the lipid level, because it allows the lipid to spread better on the ocular surface. So this is actually the LipiView showing the pre-cautery phase, where you can hardly see any movement of the tear film. You can see it's lackluster, and here the lipid level also, you're not doing anything to the lipid, but just the fact that the aqueous is there, your interference pattern is a lot better post-cautery. So case 2, this was a patient with RA with secondary Sjogren's who had undergone cataract surgery. Post-cataract surgery, there was an epithelial defect. Patient was uncomfortable, again had LipiFlow done, but it was not improving. It was almost about a month post-surgery, and she presented one eye with a central defect which was non-healing, the other eye with a diffuse staining. So here also you have already gone through all the measures. Patient is on cyclosporin, has had some sort of plugs put initially, which was not responding to that. Patient has had LipiFlow, so you need to take the next step. So here again, the investigation is showing a decreased tear meniscus height. Meibography doesn't show a significant gland dropout. So here we are basically looking at more of an ATD component. The MGD was very mild. We went ahead and did a cautery, and just it's almost like 1 or 2 days post cautery, the defect has almost healed. The surface staining has improved. So it's important to identify the component which is more causing the issue and treat that, and address any other issues also. Again, this patient was also referred back to the rheumatologist to hike up the systemic medications, understand the disease activity, and be sure that that is not something which is aggravating the dry eye as such. So when you're looking at a patient with systemic condition with dry eye, you need to be in liaison with your rheumatologist. If you don't have access to a rheumatologist, this was a guidelines which the Cornea Society of India came out with in consultation with a rheumatologist as to what are the investigations that you can do. But it's always better, because sometimes if it's a seronegative case, as ophthalmologists we might not understand what is the clinical diagnosis. It's better to keep a rheumatologist in the loop, and they will help you guide the treatment in these patients. So how do we monitor these patients? Obviously, once you have stabilized and noted that yes, it's a Sjogren's or a secondary Sjogren's, you would want to see them every 4 months to 6 months. And if there is a worsening, obviously they'll come back earlier. But if there's a worsening of the dry eye and you have addressed everything else, then you will want to probably refer the patient back to the rheumatologist to assess the systemic condition and decide on hiking up of the systemic immunosuppression. So what would be ideal situation would be we should refer all our severe dry eye patients to a rheumatologist to rule out Sjogren's, and rheumatologists should ideally refer all their rheumat patients to us to identify dry eye, because a lot of times symptoms and signs do not match. So if they are just waiting for the patients to be complaining of dry eye, we might miss, because sometimes the duration of the disease, their symptoms become much lesser. You might actually see a lot of staining on the surface, but the patients might not be complaining, which doesn't mean that he or she doesn't have dry eye. It's actually a ticking time bomb, because the surface can break down anytime and then you'll end up with a bigger problem. So the other thing that you would see sometimes is peripheral and paracentral melts. Paracentral melts are generally more associated with dry eye. Peripheral melts are generally supposed to be more associated with immune melts. It's not sacrosanct, you can have both, but that's the general guideline that you would want to look at. And obviously if it's an impending perforation, you would need to address it with measures in terms of cyanoacrylate glue or a patch graft to make sure that you don't end up with a perforation. But what is important if you have a peripheral melt is it is indicative of a vasculitis. You will need to get in contact with your rheumatologist, hike up the systemic medication, because this vasculitis can be life threatening. So it gives you the timeline that no, this is not a normal dry eye alone. You need to act fast. You need to pump in systemic immunomodulators in terms of IVMP or hiking up the systemic medications with the help of the rheumatologist to save not just the eye but the life of the patient. So this was a patient who presented with inability to open the eye. She was a known RA patient, significant filaments on the surface, diffuse staining on the surface. You can see the number of filaments there. We initially started medications. She improved a bit. Then we did a cautery. She was stable. But you can actually see after that also you can see peripheral thinning, which indicates there was some amount of activity which was going on. We hiked up the systemic medications. Then she was stable. The parameters post cautery were also fine. She comes with a sterile infiltrate and a little bit of a thinning. Again hiked up the systemic medications along with topical steroids to control the inflammation. She was stable for almost 2 years, and then she comes with a worsening. So we've already done everything from the eye point of view. The puncta is blocked, drops are on, topical cyclosporin is on, she is on systemic medication, and then she comes with a worsening of her dry eye. We tried, okay fine, we said we'll give her autoserum tears, marginal improvement. We gave her an option of using a Prose lens. She was not comfortable, but something was not fitting into it because she was stable for 2 years. So we referred the patient back to the rheumatologist, and he identified that her parameters had actually worsened and he had to hike up the systemic medication. Once the systemic medication hiked up, the ocular inflammation significantly came down. So again, when you're looking at this patient who stopped his systemic medications in terms of RA patient, one eye is showing diffuse staining and the other eye is having a peripheral melt. So like I said, a peripheral melt in an RA patient is indicative of a vasculitis. Tectonically, you stabilize the eye, but what is more important is you need to refer the patient to a rheumatologist for systemic medication. So that's important. In terms of other inflammations, scleritis, almost about 50% of patients with scleritis, just a couple of minutes, 50% of scleritis will have underlying RA or a GPA. So necrotizing scleritis is an ophthalmic emergency, not just from the eye point of view, from a systemic point of view. And these are just photos of patients with RA having peripheral scleral melts. This was actually postulated by Foster long back, that development of rheumatoid associated PUK is usually a sign of progression of life-threatening systemic disease and is associated with increased mortality and ocular morbidity. So it's very important that you realize that you have a peripheral melt, you have to get in touch with your rheumatologist. Again, when you're looking at elective and emergency surgeries, we need to improve the ocular surface before we plan the surgeries. So you would want the disease to be under control, continue the DMARDs, you don't have to stop it. You might want to continue steroids in the perioperative period if the disease is not under control completely. Emergency surgery, obviously it will be an IVMP or a pulse endoxan and you continue with the surgery. Refractive surgery, at this point of time, probably the consensus is bearing ICL, we would not be doing any laser-based refractive surgery in a patient with a primary or a secondary Sjogren's as such. You have something called as a plus disease where you're going to be missing either an SJS or OCP, or you could have a combination of Sjogren's with SJS and OCP where you see cicatrization. Primary Sjogren's, the risk of cicatrization is not so common. So if you're seeing cicatrization, think of conjunctival diseases which can cause cicatrization. This patient was being treated as RA with methotrexate for a long time, and we actually realized that this is not RA. You can see the cicatrization which was suggestive of ocular cicatricial pemphigoid, and finally once with systemic medications we were able to salvage both the eyes of the patient. So cicatrization is not common, it's not a common feature of a primary or a secondary Sjogren's. If you're seeing cicatrization, think of some other causes. Thank you.
Thank you, Dr. Bhaskar, for a wonderful talk. I would request Dr.
Without puncture window, before and after style.
Depends on what your primary issue was. If it was you had a significant decrease in lipid levels, if your vision was blinking a lot, your vision was significantly altered, and then you do it generally for about 6 to 8 months, people are comfortable. But if your ATD is also significant, then I'm not seeing that much amount of benefit just with the
Puncture occlusion,
if the ATD is more, then punctal occlusion becomes an option. If you're addressing that and you have to address the lipid, then you have to look at either drops which have lipid or you address it with lipid lower IPA to try to enhance the lipid.
Yeah.
Chloroquine, I don't have too much experience, very limited experience with chloroquine, which was already discussed, Dr. Salman also said. And I don't think that works for the lipid flow. You have some drops which now have
Yeah, he finished
lipid
his
in
talk
the
and he went. Yes, yes, he finished. He and Simon. Yeah.
in the bottle, which can be tried. Estasis in that sense was one of the first which got sold as Dura in the US market for the castor oil component.
Yeah. Dr. Bhaskar, can you join us here? I would like to request Dr. Rohit Shetty to give a talk on immunomodulators in dry eye research to clinics.
Thank you, Dr. Paras. Thanks, Namrata ma'am, and all the organizers for this slot. My talk today of immunomodulators is not something as strong as what Dr. Sharon or Deep or the Bhaskar or Paras would speak, because those are things which has a very strong impact in more severe dry eye. This is very basic, the ones which we use in our routine clinical practice, both in cataract and refractive. I do have a research grant from these companies, but they don't have a direct impact on what I'm speaking. These are all pure run research, even before the companies adopted and accepted these drugs. When you look at the ocular surface, this is a work done by Sharon as part of her PhD. She's going to defend next Monday, at the same time. So what she did was she looked at the ocular surface cells. It took a long time, more than 4-5 years of understanding every cell components and how each of these cells have a beautiful balance of hemostasis, both the conjunctival cells and also the corneal epithelial cells, and how each of those cells have filled with all the adaptive and innate immunity cells. And this is very important because understanding this has a huge impact in how we treat and how they respond to a treatment. This is a healthy environment of an ocular surface. We use the holotomography to image. This is not the live human cells. These cells are from on a Petri dish. Uses a very high definition confocal imaging to study it. And you can see how a dead cell is eaten up by the neighboring cell. The neighbor takes care of its neighbor when it dies, and it gulps it, digests it. These are lysozymes. You create an ocular surface environment which is similar to a dry eye, post-refractive. There is no cells which can take care of the other. Everything dies, and there's a tremendous amount of buildup of inflammatory molecules. And the exact same inflammatory molecules are here, which what Sharon has published. And these cells secrete all of them. It's like your kitchen sink not been cleaned for days together, and it will pump out all unwanted stuff. So how does it impact? It impacts everywhere. Every time you rub your eyes, every time there's a dust getting into your eyes, every time there is an insult, a strong breeze, this waves happens multiple times in your as long as you're living. That means every time something hits, there's a first wave of inflammation, second wave of fibrosis. This is how the body heals, not just with the eye, any part of the body. When you have more of this unwanted excessive of these markers, like what we see here, what happens is the healing completely stops. Then it becomes a completely altered healing. You may end up in pain, irritation, scarring, non-responsive, nociception, and multiple things. So why do you need, in this era where everything has in the world has moved from a conventional way of how health is to an unconventional way, where the health is completely altered. Your food we eat is driven by inflammation. Milk is from the cows where you infuse them with steroids, vaccines. Fruits are pesticides. Everything is driven by immune cells. Everything has immune cells in it. You know, me and Sharon keeps discussing that when we have an allergic conjunctivitis patient, you stop them from certain foods, products, the child gets better because it's a dry which is sugar. Sugar itself is one of the most potent immune trigger in the body. And that's why the diabetes is not a sugar induced one. Diabetes is induced by inflammation. And that's what we are here. So when we look at immune modulators, there are immune stimulants and immune suppressants. And immune suppressants can be, you know, there are a lot of drugs today like monoclonal tyrosine kinase inhibitors and all that. But when you look at immune modulators, there are one which prevent apoptosis, cascade system you can reduce, and healing of cells. They're very simple ones. I'm not going into the more specific ones, which I think would need a longer time and a different time to discuss. So when we look at certain things which we started, and this was the same platform maybe 7 or 8 years back when my PhD fellow then Natasha won the Rangachari for bringing in a concept of trehalose. At that time it was not a drug, it was, that's how you connect. That's why I like AIOS, because many things what we discuss today becomes reality, and this is a classic example. Namrata ma'am is here, how you bridge a classic animal-based experiments to a drug which has multiple uses. And one of the things what autophagy-driven trehalose does is it makes the cell to become stronger to swallow the cells which is dead. When it does that, it has a role in creating autophagosomes. Autophagosomes are nothing but a small pouching here, which kind of lyses the unwanted stuff and recycles it. And cyclosporin works on a different mTOR pathway. Again, has the same work of how you kind of work on cell lysing. It's not just like an antibiotic which blocks one part of the bacteria. It doesn't kill anything. It just alters the medium of how it works. So when you look at the same experiment here, and these are all healthy cells. These are all the lysozymes which are all moving around. They're your chemical messengers. They move from one cell to the other, send information. You create a model exactly like a dry eye. Complete absence of this. That means there's absolutely no message passed. The cells are just dying. This happens. You will get a new cells, but this happens every time we get the hyperosmotic stress. But when you use with trehalose or any of these medications, see the same cells regenerate. It's not exactly like what a normal is. You can see the organelles are not fully formed, but it will create it. If you keep this for a little longer time, it will start working. That means the immunomodulators is not going to knock off an immune cell. It's just making the cell to breathe and work better, to function better. So we used different immune cells on this experiment, and what we found was when you create an hyperosmolar status, which is similar to a dry eye state, you create a complete, if you create a hyperosmotic status, the inflammation drastically drops down. But when you use with the drug, you don't change the hyperosmolarity, but change the way the cell function to a particular stress. And that is how this whole mechanism of neurogeneration immunomodulators work. But this is a very important slide, and this is what I want you to take home. When you reduce sugar, it's not the insulin resistance which changes, it's the inflammation which changes in diabetes. So we all has been said that you reduce sugar, reduce carb, you suddenly make the cell less glucose, not glucose, it's inflammation. When the inflammation reduces, the cell starts breathing better. So what we did here is something very similar. We took the keratoconus collagen, this is a nuclei of a collagen, lysyl oxidase. You create an inflammation mechanism exactly like what you see in keratoconus. The collagen nucleus is dead. You don't see the same picture here. But minute you bring in trehalose, the collagen synthesis suddenly appears. And then you bring inflammation with trehalose, the collagen is still holding on. That just means that any part of the body, you don't need to knock anything off. You just have to reduce or target and make the inflammation more stable. And this is exactly one picture of it. Now, how does it translate to reality? We used, this is the kit which is now for people who want to use it. We tried to look at all the markers, what we said. These were all the known markers which has multiple rows. There are many more panels which will be added to this. And now we have an AI also built-in report. So when you have a targeted way, for example, this is the high level of inflammation without steroid. When you're trying to bring it down, your dendritic cells and T cells in your confocal disappears. When it disappears, what it does is it brings in exactly this picture. It brings in the collagen to resynthesize. It may happen in diabetes, it may happen in lung, it may happen in liver. The same thing happened in COVID. The IL-6, which is the interleukin 6, was the major factor why we got the lung fibrosis and people died during that time, because this is one which causes complete tsunami of COVID, what you saw that, the COVID storm. And when you reduce, people were hitting with steroids. That was not probably the way, because it had other issues. When you modulated it with different drugs, what happens is completely change the T cell driven thing. This is exactly like what had happened here. The entire dendritic cells disappeared and MMP9 dropped down. When it drops down, what happens is, we have, I think, we and Sharon and Pooja are working on this thing. This is not a single patient, it's cross-linked patients. We have more than now 100 odd patients over 3 years just with this lubricants, and you can see that every single patient has a flattening, which is exactly like what you see with post cross-linking. It just means that cross-linking may be a very end stage of what you probably don't need to do. If you can modulate the state of immune health of the person, you can get the same results. And this is the collagen imaging. This is a collagen with lighter blue means there's no collagen properties. These are all ones we use the cyclosporin, the Sequa 0.9% and trehalose, and you can see the changes happening. The collagen is resynthesizing. This exactly matches to my previous picture here from the animal work, that collagen can resynthesize if you reduce the inflammation. And that's the most powerful thing, and you can reduce the T cells completely off just using a immunomodulator response. Cyclosporin has been used in multiple ways. It works on T cells, calcineurin inhibitors, but it has other role also, apoptosis of cells, and works on how the T cells is. Again, we have worked multiple areas on multiple diseases, nerve regeneration, post-op cataract, nociceptive issues, when patients have more nociception, and multiple areas. There are too many cyclosporin. What we did was we tried to look at a lot of cyclosporins in the market, and what we found was cyclosporins which are very cheaper may make you feel happy, but it gives you this kind of results. We can see some places here, the cells are all dying off. That's why you get irritation, you get pain with certain cyclosporin, because instead of doing what it's supposed to do, it's killing off all the cells. A good cyclosporin should not damage the cells, should actually make it feel better. I'll just take a minute and then I end up. And this is how we are using, when you combine with this is what we can able to achieve. We can see that just without steroid, we can modulate the entire inflammatory molecules of our body. The last one is the resveratrol. It's one of my new areas of interest. It's the wine grapes, the seed, the cover of the grapes, and this has again a huge role in building the collagen. It's reduced the TIMP1 activities with the inhibitors of MMP9, and you can see that it withstands the eye to an oxidative stress. So to sum up here, we have to understand that lubricants, cyclosporin, and all these other things, resveratrols, have a huge area other than just what we have been told it works. It can probably be a biostimulant in ways it's working. And that's why we need to look at this in our post-operative and other areas and other areas where you want them to, when you want the tissue to regenerate. Thank you.
For a wonderful talk. If we can take one or two questions before you leave. If you have any question for Dr. Shetty, we can take one or two questions. Meanwhile, I would request Dr. Namrata Sharma to set his... Yeah, it's already there. Shall we? Have any? Oh, okay.
Use, in what concentration, when should you use it, and what are the features of each. So basically the topical non-steroidal modulators, immunomodulators such as cyclosporin, these are used in dry eye disease. In step 2, when the patient education modification of local environment or ocular lubricants don't work. So there is rationale for using of the anti-inflammatory agents like steroids, cyclosporin, etc. in the management of dry eye disease, but there are also challenges. Now the challenges are because there is low adherence and high rates of discontinuation in the dry eye disease therapy. 70% of the cyclosporin 0.05% patient and 64% of the patients with lifitegrast, they discontinue their treatment within 12 months of initiation. This is mainly because there's burning and there's stinging and there's lag time between initiation of the treatment and the symptomatic relief. So this is just to show that if you compare cyclosporin with lifitegrast, the dry eye disease signs or the tear production significantly increase at 6 months. Now there is problem with the existing formulations as far as the cyclosporin is concerned because they are thermodynamically unstable, they have poor ocular tolerability, and they must be shaken to resuspend the drug particles. At the top of that, they can also cause blurred vision. So this is the anatomy of the N cell, which is overcoming the aqueous solubility. Basically, it has a hydrophobic core and a hydrophilic shell. And the protective hydrophilic shell allows for transport through the tear film into the ocular surface when the secured hydrophobic core begins to act. So this is basically the N cell technology which encapsulates, helps to penetrate and delivers. So as a result of which the penetration, it increases. Now, when this cyclosporin emulsion 0.05% was compared with this cyclosporin, which is made with the N cell technology, it was found that the nanomicellar cyclosporin had better concentrations both in the conjunctiva and the cornea as compared to the one which is commercially available as suspension. Then there are studies which have been undertaken, phase 2, phase 3, and long-term safety extension studies, all of which show that the nanomicellar cyclosporin is better. Just to briefly highlight these studies, one of them when it compared cyclosporin, this OTX101 is the one which is the nanomicellar one versus the vehicle and versus the cyclosporin 0.05%. When they were compared, it was seen that the results in this nanomicellar cyclosporin or CEQA are as fast as 2 weeks. And so there's improvement in total corneal staining after 14 days. If you take the other brands of the cyclosporin, it takes a while to get the symptomatic relief, and that takes a minimum period of 6 weeks. Now, this is yet another study of 744 patients which compared the nanomicellar cyclosporin or the CEQA with the vehicle, and the treatment lasted for 12 weeks. Again, the total corneal staining which was seen at 1 month was significantly better with CEQA as compared to with vehicle. And patients also reported reduction in the symptom severity with the nanomicellar cyclosporin and also improved the global symptom score. As far as the visual acuities were concerned, even they were found to be better with CEQA than with the vehicle, which is expected because they would improve the corneal staining and the surface would become more optimal. Now, this is just to show that at 3 months, 65% of the central corneas were completely clear, and at baseline, 38% were taking nanomicellar cyclosporin 0.09% had complete clearing versus 37% with the vehicle. Now, this is the real world treatment patterns in patients with dry eye disease because in other countries, this is given by the insurance. In our countries, it is not. So they actually saw the data of the health insurance and they found that the nanomicellar cyclosporin ophthalmic solution lasted for a longer period of time because those patients were taking their bottles or were taking the drug from the insurance, through the insurance, whereas the other cyclosporin, that means the 0.05%, and both liftigrast, there was a dropout much earlier as compared to the nanomicellar cyclosporin or Sequa. It was also very comfortable to most patients at the start. Now, if you see the normal cyclosporin, 17% of the patients would complain of stinging, which is not so here. And there are no reported taste alterations. This has basically been done because with liftigrast you do get taste alterations, but this does not happen here. And there is incidence of blurred vision or mild stinging, which may be there in less than 1% patients. Now, this is for the long-term safety evaluation of 0.09% cyclosporin. And again, in this, in long-term follow-up also, when it was compared with the vehicle, there were no side effects, and it was well tolerated during a 1-year long-term safety phase. With any brand of cyclosporin, this remains an issue as to how long can you give them. Now, this is a study which was done where the change in the tear production was studied, treatment with Sequa or restasis. And Sequa twice daily significantly improved the tear production versus restasis twice daily on days 45 and day 60. Concomitant use of artificial tears is also useful with it, and it does not in any way jeopardize the relief of the symptoms or the objective parameters which were studied. And co-treatment with topical steroids, which may be required in some cases, especially when it gets very severe, to break that vicious cycle, is also found to give good results and optimal results. And when the cyclosporin does take over, then the topical steroids can be tapered off after that vicious cycle of dry eye disease and inflammation is broken. So again, this is just to show that biometry and high order abrasion in dry eye patients, especially who are undergoing cataract surgery, if you give Sequa cyclosporin, they do improve. So to conclude, from day 1, there are no or mild installation side pain, which is seen in more than 95% of the patient. After 14 days, nanomicellar cyclosporin 0.9% improves the corneal staining. At month 1, patients achieve statistically significant reduction in the total corneal staining and reduction in the symptom severity. As early as day 56, nanomicellar cyclosporin improves the visual acuity. At 3 months, the 65% of the central corneas were completely clear and tear production nearly doubled. And after nearly a year, more patients are still using nanomicellar cyclosporin as compared to the other formulations and other drugs. Most common adverse event is the installation side pain and the conjunctival hyperemia, which is really mild and really not too much. So currently we are doing a randomized control study where we are comparing restasis patients with Sequa patients in dry eye disease, and no financial interest of interest of conflict, but we are going to come out with the results soon. So thank you very much for your kind attention.
Thank you, Dr. Namrata, for that lucid talk. We can.
It is freely available, sir. Freely available. It is, I feel it is, I should say more effective, but the duration of action is much faster. 2 weeks as opposed to 6 weeks, which other cyclosporin formulations do. So that way it is more effective. Also, the penetration is much more because of the unique N-cell technology that it encompasses. So the bioavailability is much more, and it is tolerated well by the patients, and the stinging sensation is much less. This Sun Pharma is making it, sir. Sun Pharma.
Quickly, we can take one question for...
Sorry? Sequa. You can use in VKC. We are using in vernal keratosis. Wherever you could use your earlier cyclosporins, you can use here. No problem.
Yes.
Nanomicellar is nanomicelles. Nano means very small. Micelles are the components in which it is encompassed. The molecule is encompassed. Micellar because it is kind of, it has a hydrophobic inner part and it is covered by a hydrophilic shell. So that resembles a micelle, that's all.
The next session is on, and so we are sorry for that. We started late for almost about 15 minutes, so we'll not be able to take any more questions. But I would like to thank all the speakers and the panelists for the same. Thank you. And for